morning. Welcome to the 2016 Debra L. Spunt Lecture, generously funded by Laerdal Medical Corporation. My name is Amy Daniels, and I am the director of the Debra L. Spunt Clinical Simulation Labs at the University of Maryland School of Nursing. I was privileged to know Debbie in her early years of teaching during my undergraduate nursing program at the University of Maryland in 1989. As a pioneer in clinical simulation, Debbie directed the development of the School of Nursing's 28 clinical simulation labs, and our labs are proudly named in her honor. This year's Spunt Lecture will incorporate interactive moments through the use of Poll Everywhere, as many of you have already started using. In preparation for that, for those of you that haven't already started, we've provided information on the screen for access. For those of you that are pretty tech savvy, feel free to use the QR code with your QR app. All others, please simply text J Palaganas to 22333. Additionally, Janice's references are available via QR code on each screen for open access publication. In addition, a list of references will be posted on the NLN app after the presentation. This will permit you an opportunity to sit, enjoy, and relax while Janice presents to us today. Now that we have these housekeeping items taken care of, as the Spunt Lab Director, it is my honor to introduce this year's Spunt Lecturer, Dr. Janice Palaganas. One of Dr. Palaganas' first jobs in simulation was as the first chair, then implementing director, of the Society for Simulation in Healthcare's Accreditation and Certification Program, leading to the development of simulation standards for program accreditation and educator excellence. She continues to train and mentor SSH accreditation reviewers in preparation for site reviews. Currently principal faculty and director of education innovation and development at the Center for Medical Simulation at Harvard, Dr. Palaganas has taught students who today are leaders in healthcare. She demonstrates her commitment to scholarship in various ways. As editor-in-chief for the Society for Simulation in Healthcare's first textbook, Defining Excellence in Healthcare Simulation Programs, published in January of 2015. By writing book chapters and journal articles, 3 of which are considered seminal. By reviewing articles for several journals, including Simulation in Healthcare, the Journal of Patient Safety, and Nursing Education Perspectives, and much, much more. Dr. Palaganas was a simulation author for the NLN's project that explored using simulation for high-stakes assessment. She was an invited member of the NLN debriefing think tank and was selected to chair the Interprofessional Education and Healthcare Simulation Symposium sponsored by SSH and the NLN. Axel invited her to the development team for Standard 8 on simulation, simulation-enhanced interprofessional education, and she was the first simulationist involved in an Institute of Medicine IPE report. She shares her knowledge and passion about simulation and IPE through regional, national, and international presentations, and as a consultant to university and hospital systems. She now turns her attention to web-based learning, leading to the creation of an online third space where faculty can develop skills related to interprofessional education. This Josiah Macy Jr. Foundation funded project will use collective, peer-to-peer, and mentor-led learning to enhance communication and reflective practice for educators working in interprofessional settings. Her global impact is felt at a very personal level by many of us, having learned from her directly and/or anyone working along her side. Dr. Palaganas describes the profound significance of this lectureship by stating, "It would be one of my biggest honors in my professional career to share with other nurse educators what Dr. Spunt so wisely shared with me." Please join me in welcoming to the stage the Debra L. Spunt Lecturer, Dr. Janice Palaganas.
10 years ago, I was at this conference. I was eating lunch, and a woman came and sat down next to me, and she introduced herself as Debbie Spunt. She asked me about my work, and I told her about my dissertation. It was a time when I had just started analyzing and collecting my data, and I remember sharing with her how discouraged I was, because my initial analysis was starting to show that everything that I had believed in interprofessional education, everything that I believed in simulation as a platform for interprofessional education, all of my predictions were wrong. And I had just made a really heavy career change. I left the hospital setting for the university setting, just so I can focus the rest of my career on this. And I remember telling Debbie that I was worried that I maybe made the wrong career choice. And what Debbie said to me changed the next decade of my life. She said, when you make a bubble, you further yourself. When you burst that bubble, you further the field. I thought a long time about Debbie's words, and as I reflected on my past, I started to think about eye-opening events that have occurred in my life, and in my mind it was like I had this one bright light, like this warm, bright light that just wouldn't turn off. So let me tell you about that. 5 years before I met Debbie, so now 15 years ago, I was a trauma nurse practitioner. And the trauma team was activated, and we all responded. And by we, I mean me, the trauma nurse practitioner, the trauma nurse team leader, the trauma surgeon, the emergency nurse, emergency physician, emergency tech, the respiratory tech or therapist, the radiology tech, the pharmacist, and the nursing supervisor. We were a familiar team. We were not new to each other. And usually, when we waited for a trauma to be flown in, it was about a 15 to 20 minute wait. This night, it was a little bit over an hour, so it was longer than usual. And I remember asking the radiology tech, who was in nursing school at the time, how's school going? And the next thing I know, we're talking about the differences in schooling, 2 years, 12 years, the differences in our clinical rotations, the edges of our practice, how we overlap, how we were trained to do certain things, but in our hospital, we didn't because other people did it. We joked a little bit about professional stereotypes. We told brief stories. We talked about the different processes that we each had to worry about with every trauma that came in. So the trauma surgeon was always worried about what was going on in the OR. The nursing supervisor always worried about ICU beds and if the patient's family has been contacted. We had 2 patients that night, one of which coded. We gave 24 bags of blood. And the way we worked that night, it was different. Smooth, fluid, efficient. And I remember we were waiting 2 weeks later for another trauma to come in. And it was the same team, probably plus or minus 1 or 2 people. And we had discovered that those 2 patients were still alive. And not only were they still alive, they were on a good pathway to recovery. And I remember how remarkably, rewardingly shocked we all were. But looking back, I'm not at all surprised, because I truly believe it was that hour before their arrival that saved those patients' lives. And that's the core of what I'd like to talk about today. What was in that hour that saved patients' lives, and how can we bring it, each of us, into the education that we provide? There was one thing that bothered me about that event. How was it that after 5 years of practice, this was the first time that I really understood what teamwork, collaboration, interprofessional practice could really look like. And as I got more and more interested in it, I wanted to understand what was the extent of this gap. And not just in my own education and my practice, but in healthcare education. And what we do know is that when we do not collaborate the way we did that night, these are the costs. Medical errors because of poor communication and conflict between professions. Adverse events. Despite nurses speaking up. Potential non-reporting of some of these incidents. We've known for a really long time that if we don't collaborate, we create lifelong patients due to iatrogenic outcomes. We've known this. Higher costs because of increased length of stay and duplication. The list goes on. And when I look at this, I think, if it was your parent, your partner, your child who was a victim of any of these statistics, because people didn't know how to work together, is that okay? So we know we need to collaborate, and we also know that the precursor to collaboration is education, interprofessional education, which you're going to hear me refer to as IPE. So there is an increasing recognized need and a huge push for IPE. The Institute of Medicine, the World Health Organization, the National League for Nursing, all of these societies, that some of which are specific to one profession, they are pleading for us to do IPE. And the size and the nature of what we do as nurses, the fact that we overlap more with other professions than any other profession, we are being positioned to do this. You, as nurse educators, you are in a unique position to do this. And what we are finding is that the environment in which learning, this type of learning occurs, where we can educate our learners to learn with, from, and about each other to impact patient outcomes. The environment in which this occurs is vitally important. And we're finding that healthcare simulation may perhaps be the best platform for interprofessional education. It is certainly becoming the most preferred platform for interprofessional education. Why? Because of what we know about adult learning, experiential learning, situational learning, emotional learning, deliberate practice, reflective practice, what we know about feedback, giving feedback, and getting immediate feedback. In healthcare simulation, you can engineer a realistic experience for almost any profession that you decide to include. How amazing is that? Simulation is powerful. So we are being told that we should do IPE and that we should use healthcare simulation. So let's do it. And let's do it right now. So, okay, before I jump into this activity, I do feel the need to ask for your permission to go on this exploration with me, because I feel like if we're going to dive into simulation-enhanced interprofessional education, we need to really dive into it. And so what it'll entail is getting into some discussions with some of the people around you and then sharing your thoughts on Poll Everywhere that will go up on this screen over here. So if you're willing, I'm going to ask for you to meet me halfway in this talk. I see a lot of head nods. Thank you. It's very affirming for me up here. So great. Let's take a dive. So what I'm going to do is I am going to play a simulation for you, a case. And by the way, this is not a real case. It's not a real simulation. It was created for the purpose of activities such as this. And what I'd like for you to do is I'd like for you to view the case as if you were the educator and you are watching your learners in a simulation and you may debrief them. So this was a post-thyroidectomy patient in the PACU. The patient has an expanding hematoma that is compromising her airway. You might develop a case like this if you're looking at steps for speaking up, if you're looking at communication between a nurse and a resident, or if you're looking at the management of an urgent airway issue. We're going to have two learners. We're going to have Tina, our experienced PACU nurse, and then we're going to have Rory, who's going to be our resident. So just to refresh instructions here, if you can watch this case as though you are the educator about to debrief your learners, Tina and Rory. What I'm going to be most interested in are your initial reactions. So as soon as the video stops playing, if you will take out your electronic device and type in a reaction or an initial thought that you might have. Okay, so let's play this video.
Yeah, hi, Rory. Yeah, this is Tina. I'm the nurse over here in 5C, and I'm calling about a patient. Remember Mrs. Cullen who had a thyroidectomy, a total thyroidectomy this morning? Yeah, that's the one. Well, she's not looking that good right now. I think you need to come over and see her right away. I really need you to come right now. Listen, here, I can settle this. I can call your attending, and your attending can come over and see Mrs. Cullen right away. Oh, okay. Good. I'll see you shortly. Okay, get here as fast as you can. Yeah.
Hey,
Rory,
what's
it's
going
so
on,
good
Tina?
to see you. Well,
What's going on?
Look at her. Look at her.
Okay.
You need to do something.
Mrs. Cohen? Mrs. Cohen, this is Dr. Cartwright. Are you in any pain?
This isn't pain.
Mrs. Cohen?
This isn't pain. You gotta do something. She's not breathing.
Do you have a stethoscope or something?
She's not breathing. You gotta do something.
Mrs. Cohen, I'm going to take a quick listen real quick to your breaths, okay? Nice deep breaths.
You gotta do something.
How long have your stats been like this?
It's been since I got off the phone with you. They've just been dropping down.
Alright, I need you to call the code team, call anesthesia, and call the OR immediately. We need to get her back in there now.
We don't have time for all that. I can press the cold blue button.
Well, I need you to call the code.
You gotta do something.
Alright, well,
We
we
don't
need to
have
get
time to take her
everyone on
back
board.
to the operating room.
Here you go. We'll do that. I need to go call my attending.
Come on.
What's going on here? I heard you had a
Yeah, I was just gonna call you.
this is an expanding hematoma. You gotta
Yeah.
open it.
Okay.
Give me a suture kit right
Okay.
away.
All right.
Right away.
Yep. Okay.
This is Cullen. Yeah. Okay. Give me a suture kit. Get in here and help me out.
Okay. There you go. Okay.
All right. Get some suction.
Okay.
Get in here and help me out with that suction.
Okay.
Okay. Keep that suction going.
Okay.
This is Cullen. This is Cullen. Take a deep breath. This is Dr. Bayfield. Take a deep breath for me. Get the suction in there. Keep it going.
Okay.
Yeah. Anytime you have an expanding hematoma, you have to open it. You have to
Okay.
open it right away.
All right. Understood.
Get that suction in there. Good. Okay. Yeah, you open it right at the bedside here. Anytime. Expanding hematoma, that's what you gotta do.
Okay.
Think expanding hematoma. Open.
Okay. Understood.
Okay, so let's take a minute for you to take out your electronic devices, and if you can type in any reaction, initial reaction or initial thought that you have. Bruce, I do need to get over to my other screen here. Hold on a minute. There we go. Okay, hold on. Don't type in your reaction yet. You're still at the animal screen. Oh, I need the split screen, sorry. Thank you. Okay, so now it's ready for you. Let's take a minute to do that. Lack of accountability, poor communication. Reaction time is too long. lack of communication. And trust, important. Poor teamwork. Ow. Poor communication. Okay, let's take about 30 more seconds. Okay. All right, so what I'm going to do here is I am going to minimize this screen here. If I can get over there. Technology is so beautiful. I can't see. Am I on the yellow? Okay, good. Thank you. Okay, so you have seen us minimize the reactions here. I'm going to ask us to do that internally as well. So if we can try to internally minimize our reactions, to be clear, I don't want you to close out of the window. I don't want you to delete it or dismiss your reactions. Those are important. I just want you to minimize them if you want to think of it as putting it on standby, just to get yourself in a position where you can discuss something else. Because what I'd like to do now is to get into groups of 3. So find 3 people sitting next to you, and then what I'd like for you to do is still stay in your role as the educator, having just watched your learners. And I'd like for you to discuss, and by the way, we only need 1 response from each group, so pick 1 person to send in the response. And if you can brainstorm together, after this simulation that you have just observed, and after the debriefing, which you have not done yet, what 1 thing would you like Rory and Tina to do or think better next time? So what's 1 thing that you think is crucial for Rory and Tina to learn after observing them? Let's take 2 minutes. S-bar. They all have the S-bar in it. C-U-S, cuss. Love it. S-bar and cuss if necessary. Take initiative. Okay, let's take 10 more seconds. Good. So what I've done here is I've summarized some of the things that you've said. I didn't put cuss in here, I should have, sorry. So let's say that cuss is like number 2. We'll add a number 2. So now that we know what we are looking to achieve in the debriefing, I would now like to go to the debriefing. So I'm going to need a little more help here. And I think the best way, I'm going to need help playing the role of Tina and Rory. And so I think the best way to do this is to just divide us down the middle here. So for this side, if you could step into Tina's brain for a moment, and this side, I know it's kind of scary, if you can step into Rory's brain for just a minute, and we are going to keep the same trios, so we are going to still just need 1 reply. I will be debriefing you, and when you reply, this is really important because the feed over here is going to be 1 feed, and I think it might be important for us to know if it's Tina's reply or Rory's reply. So please, those of you who have become the electronic device representative in your group, if you can type in Tina, if you're on this side, preceding your reply, and then Rory, if you're on this side, preceding your reply as well. So I'm going to do the debriefing. And by the way, guys, I just asked you to do something unusual. I never ask anybody in debriefing to be someone who they're not. I typically don't because often I see them act out the stereotype that I'm trying to break down. So I think the way it could work for today is whomever you're thinking like, if you can think as though that person was really trying to do their best. So, okay, so let's go to the debriefing. After I initially get reactions from Tina and Rory, then I might ask a question of exploration, trying to understand what were the thoughts that were driving the actions. And so what I'd like for you to do is I'm going to ask a question and then in your group think of a reply. So I want to get at the level of why they did what they did. So it might sound something like this. Okay, I'd like to talk about the management of acute respiratory distress. So Tina, I heard you at one point say that Mrs. Cohen wasn't breathing and for Rory to do something. And Rory, I also heard you say that we needed to take Mrs. Cohen to the OR. I was getting really worried that Mrs. Cohen would stop breathing altogether and go into respiratory rest. So what was going on for each of you at that time? Okay, so if you can get into your groups and think of a reply from Tina and from Rory. So Tina's saying, I panicked. Rory's saying, getting patient to someplace where there was help. I didn't know what to do in this emergency. The patient needs to go back to the OR. Rory was tired and afraid. Okay, let's take about 10 more seconds. Okay. So what I'm pulling up here are a couple of Tina's perspectives and a couple of Rory's perspectives. And what I'd like to do here is put some of our reactions up in a word cloud above. So here's the really interesting thing, is here are our reactions and how Rory and Tina are thinking at the moment. And over here is where we'd like to be by the end of the debriefing, or at least in a way where they can take some of it away. And what's in between this gap is just us. And we have the responsibility to find a way somehow to bridge for our learners, getting them over here, from here, all the way over to here. So I would like to demonstrate for you through 2 interpretive dances what we are expected to do and what it really looks like. So this is what we're expected to do, right? So, okay, Tina and Rory, I would like to teach you the interprofessional collaboration dance. Okay, so Tina, stand up. Okay, elbows up. And you're just gonna follow me and twirl. Okay, do, 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 do. Great, Tina, just wait right here. Rory, yep, your turn. Okay, same thing. Yep, turn and do, 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 do. Okay, Rory and Tina, great, you're here. You two dance together now, and I'll talk you through it, okay? A little bit closer. So, and 1, and 2, and 3, and 4. Good. 1, and 2, and 3, and 4. Great. And here we are. Great. Let's hold hands and sing a hymn. It is not that easy. It's not that easy. Erase it from your minds. It's not that easy. This is what it's really like, okay? So we're all the way over here. And here are our reactions. They make us awkward in our dance with our learners because we are feeling this, and we are supposed to be learner-centered, so we're supposed to be able to listen to them, but the whole time we're like, oh my God, I can't believe that they just did that in simulation. I sure hope they've never done that with a real patient. And you turn around and they're not following you. And of course they're not, because they're over here like this. So Tina's like, okay, what Rory really needs to do is schedule simulations to just learn how to open hematomas, right? And then Rory's like, Tina needs to go to communication school. And meanwhile, we're all the way over here. So we have to find a way to like rewind, maybe turn around, and you might stumble a little bit, and you're like, I hope they didn't see that. And then it might look something like this. So now we're like trying to push them somewhere to the middle. And we get to here, and you're like, oh my gosh, what other moves do I have? How can I get them talking? How can I get them learning from each other? So you just like start busting out something and hope that they'll do it with you. And then in that moment, maybe they do. Now they're talking, and you're like, okay, I glanced down at my watch. I only have 5 minutes. Great, we're over here. At least I got them unstuck, but we need to be over there. So, okay, guys, let's, scoot down this way. Let's go. And now you're just kind of walking quickly, and they might not be following you, and you're like, okay, well, I have only 1 minute. Maybe I should just tell them what to do and hope that they're standing here with me. What we do, it is not easy. What we do is not easy. And as educators, we have the ethical obligation to bridge this gap. And so I'd like to offer us a reframe to, let's try not to think of it as a gap, but let's think of it as a one-time opportunity. Because when are you going to have Rory and Tina in the room with you again, hopefully feeling safe enough to discuss their performance, that exact performance that they just did, that identified for you where you could help them? When are you going to have that opportunity again? And you've got this stage, it's big. You've got the creative licensure to try to work with your learners to move them across. And so the educator dilemma becomes, well, how do we take advantage of this one-time opportunity? And how do we create deep interprofessional learning? How do we create an experience that is sticky enough that, these are adult learners. They're going to learn when they want to learn. They might not learn right at the end of their time with you that day, but they might learn later on, weeks later, months later, years later. But how do you create an experience that's sticky enough that they can reflect on it later, or sticky enough that they may have learned in their time with you that they can now apply it in their practice in a way that you, in your time with them, have now impacted patient care? How do we do that? I believe it takes 4 ingredients, these 4 ingredients. And I'm going to unpack each of these one at a time. Before I do, I have to acknowledge my colleagues at the Center for Medical Simulation, because my mentors, Jenny Rudolph, Robert Simon, Dan Raymer, Jeff Cooper, my colleagues Mary Fay, Kate Morse, we have worked over the last years really massaging these concepts, really practicing them, shaping it into what I present today. So the first ingredient, a common experience. When I think of boundaries in healthcare, I think that it is the difference in who we are and how we think, dressed in our profession. And the problem is that we cannot see what another person's thinking. The only way we can see what another person's thinking is to talk. And it is very difficult to talk with someone when you feel like you have absolutely nothing in common with them. And when you feel like you do have something in common, it's easier to talk. And when you have a common experience, you have purpose to talk. In sociology, there is a well-known concept called boundary objects. And what a boundary object is it's a physical object that is used by different communities. So to simplify this, think of art class. If you were painting a fruit bowl and you walked around the room, all of the paintings from all of the art students are different. Why? Because we have different perspectives and we have different abilities. But when you look at the fruit bowl, it doesn't change. And the best thing about that fruit bowl is we all recognize it as a fruit bowl. So in healthcare, a boundary object might look something like this, so a blood pressure reading. Bring a healthcare group together. They all use this information in different ways. And this is important for us because in sociology, boundary objects are key, are seen as key in developing and maintaining teams that are made of different professions. Because what it does is it validates that you have your own perspective. And it also allows an openness and an appreciation that there are differences and that people use it differently. This next ingredient, I think, is 100 times harder than it is stated right here, and I'll explain why I think it's so complex using the concept of the ladder of inference. The ladder of inference comes to us from Harvard business professor Chris Argyris, and what this concept says is that with every event, there is data. And what we typically do as humans is we select from that data and we shoot up this ladder of inference, which is something that we have to do to be able to function in society. In education, it can get us into trouble, and this is why. So let's say you have a student who you've noticed is late for clinical. So you've noticed she's been late for clinical 3 times, so that's data that you've selected. And what happens is we naturally start naming it. So we're saying she's irresponsible, and then we start drawing conclusions. She is not going to be a competent nurse. And then what happens is we start taking actions, and when we take actions, we create more data, but this is where we get into trouble. Naturally, the conclusions we draw, the assumptions that we make, tell us which data to select. So I might be following that nurse around wherever she goes in clinical, or that student around, and I'm only going to be selecting data that proves that she's not going to be a competent nurse, that proves that I'm right. It becomes a self-fulfilling prophecy. And so we have these reactions, and when we have these reactions, it means we're up the ladder of inference. And we have to find ways to climb back down. At the Center for Medical Simulation, we have something called the basic assumption. We believe it is the crux of education. It is so important to us. It's on our walls. We read it with all of our students. I'm going to read it to you right now. We believe that everyone participating in activities at CMS is intelligent, is capable, cares about doing their best, and wants to improve. It sounds so sweet, but when you're in the middle with students, it is so hard to hold. And if you can hold this basic assumption, what it does, it puts you in a stance of curiosity, and it puts you in a better position to meet your learners where they're at, to figure out what their needs are. So for example, how many of you have had a student where you're like, how did you get this far in this program? Right? Instead, think, you are intelligent, you've made it this far in this program, what am I not seeing? And how many times have you had a student where you're like, he just doesn't care, he is not even trying? Instead, think, he's capable, he cares about doing his best, he wants to improve, I have to figure out what is holding him back. Because just as when you are up that ladder of inference and you think your student's an idiot, just as your student knows, they can sense when you think they're an idiot, it's the same. They can sense when you are genuinely curious and that you care about helping them improve. So we have these reactions, we quickly go up this ladder of inference, we're already up here with reactions. And if you can use the basic assumption, it can serve as an anchor back down that ladder of inference. This third ingredient has everything to do with discussion and creating opportunity for a conversation for your learners. So Anderson and Galician talk about meaning systems, and what they say is that to create new meaning systems, you have to first reveal and share individual meanings, individual perspectives. So think about the 6 blind men and the elephant. The most efficient way for these men to know that it's an elephant is to talk and reveal and share their perspectives. It is no different in healthcare. We have to find ways to talk. We have to find ways to have a conversation. We have to get into a talking dialogue where we are able to understand each other's thoughts and understand the edges of each other's thoughts. We need to understand our bounds the different bounds, to get to common ground where there are no bounds. We need to know bounds to know no bounds. And this last ingredient leverages a common goal while keeping in mind different perspectives. So recall this image here. It's interesting because when conflict arises in a group, it is because they cannot see their differences and they don't work to understand it. And if those differences are revealed in a debriefing, let's say, or in any education, by simply illuminating their differences, simply illuminating their boundaries, you can steer them in the same direction for them to problem solve, still taking into account all of their concerns. Okay, so I think these ingredients are big to swallow. So what I'd like to do is make them a little more bite-sized, make them a little more tangible to you. So I'd like to rewind to what we did with Rory and Tina. So with Rory and Tina, in healthcare simulation, your boundary object is your simulation. By creating a simulation and allowing your students to go through it, you have created for them a common experience. You have created purpose for them to talk. You can pause this video or try to objectively describe anything that had happened that you observed, and that can serve as a boundary object where you can now explore boundaries and differences and talk about them. So we did this. I said, okay, everybody get out their electronic devices, type in what you're thinking, and these were our reactions. Most of us were around the right side of this emoji spectrum here. And then I asked you to minimize it. I said at one point, okay, let's internally minimize it. And so we tried to do this. There are times where your reactions will be so grandiose that it often feels impossible to minimize them. And in my experience, trying to overlay my reactions with the basic assumption, trying really hard to hold on to the basic assumption, is what makes me more flexible, me more stretched and ready to be able to move with my learners however they need to move to get over to the other side of the stage. So this ingredient is why debriefing is the heart of learning in simulation. We have a saying at CMS that simulation is just an excuse for debriefing. And this is why, and especially in simulation enhanced IPE, this is why, because you are creating an opportunity for them to reveal their perspectives and create new meanings. So for Tina and Rory to see the elephant, to see what the real issue is, they need to be able to talk, have a conversation, have a debriefing where they can reveal their own perspectives, and perhaps you can help guide them towards shared meaning. Okay, so this one, sometimes when I'm doing my kind of debriefing dance, trying to get my learners across the stage, there are times where I'm just completely paralyzed. And usually there are times where somebody says something that you just really don't expect. Maybe it's a little appalling, or you're afraid that there's this conflict that's going to, arise and people are going to start arguing. Well, that really kind of paralyzes me. And this ingredient has saved me. So we're going to try that. We didn't do this with Rory and Tina, so let's try that. So let's say we're in the debriefing with Rory and Tina, and you ask them a debriefing question, and these are the perspectives, the replies that you get. It's like paralyzing. So throwing this ingredient into our debriefing soup, it might sound something like this. So, Rory, Tina, I hear your frustration. Rory, I know what it's like when you feel like you're being called all the time. Tina, I know what it feels like when you feel like someone's not listening to you. But here's the thing, guys. We have to keep Mrs. Cohen safe. we have to make sure that she keeps breathing, that she's breathing. So when you have moments like this, what are some things that could work for you if this were to happen again? In healthcare simulation, coming up with that common goal, it's often pretty easy because it has something to do with patient safety. And in my experience, when you use those words, patient safety, it defibrillates egos. And it defibrillates the conversation in a way where it illuminates for the entire room how their differences are impeding on quality patient care. And that is achieving deep interprofessional learning. So when I think back to my experience 15 years ago in the trauma bay, I've made it my professional mission to try to understand what was in that hour that saved patients' lives and how can we bring it to the education that we provide. And I believe that in that hour, what we were able to achieve was mutual respect and appreciation for differences. And this one is the one that really sticks with me. An appreciation that we all care about the same thing, just in different ways. And that is necessary for the patient. The patient needs us to care about them in different ways, and they need us to work together. And to bring that into the education that we provide, I believe that this is a good starter kit. So, over the last decade, I've gotten lots of things wrong, lots of bubbles that I've burst. And to close this talk, I thought I would more explicitly share a few bubbles that I've burst in hopes that you'll take them and further this field. I used to believe that boundaries make IPE challenging, that we need to go beyond boundaries to learn together. And what I have come to appreciate is that boundaries make IPE interesting, because in IPE, learning is at the boundaries. I used to believe that simulation was the solution. And quite painfully, I have come to find that simulation is just a diagnostic tool, perhaps the most powerful learning diagnostic tool that you can use, but that you are the solution. We are the vehicle for achieving collaboration and learning. So 10 years later, if I had the honor to have lunch again with Debbie Spunt, I would tell her that we should always try to burst our bubbles. Thank you, Debbie.
I think we all feel how beautifully she did this. Janice, thank you so much. Thank you for sharing your insights on moving beyond boundaries. Thank you for taking us on a journey. And now I want to extend my sincere appreciation and sincere thanks to Laerdal for making this session possible and for partnering with the NLN on so many projects. The Simulation Resource Center, CERC, the ACES project that we have all become familiar with our friends Millie, Red, Henry, and Julia, and Lucy, as well as our veterans cases, our simulation solutions for nursing, and our latest project, Accelerating to Practice, which you're going to hear a little bit more about in a few minutes. Laerdal's been an extraordinarily supportive collaborator for the NLN since 2003. It's been a privilege and an honor to work with our colleagues there They have a clear mission to save lives. Isn't that what we're about? They have strong values that permeate the organization, values that resonate with our core values of excellence, integrity, caring, and diversity. So please join me in thanking Laerdal for all they've contributed to saving lives. And now I invite Clive Patrickson, CEO of Laerdal, to come to the podium to make a special presentation. Clive.
Janice, you want to come forward? On behalf of Laerdal, on behalf of the NLN, we'd really like to say a big thank you to you for a fantastic presentation. You can... I'm doing the dance. I'm doing the dance.
Here you go.
I've been following the moves, Janice, so I want to say a big thank you to you for making a fantastic presentation. And I think I've seen every Debra Spunt lecture for the last years. How many years is it? 6, 7 years since we introduced this, and I got to say it was truly stimulating. Thanks very much indeed.